I'm Ming-Yan Cai from Endoscopic Center, Zhongshan Hospital, Fudan University, Shanghai, China. I'm a surgical endoscopy. This is Louis Law from Chinese University, Hong Kong. He will join me today for the author interview of an IIG article entitled Endoscopic submucosal dissection for advanced rectal cancer after neoadjuvant chemotherapy, optimizing treatment strategies.
Hi, Ming-Yan. Thank you for your invitation. I'm Louis Lau from the Chinese University of Hong Kong. I'm a gastroenterologist with special interest in advanced endoscopists. And I think your paper is very interesting, talking about minimally invasive resection following a neoadjuvant chemoradiotherapy. It usually refers to a transanal microsurgery. So why did you choose ESD in this case?
Yes, you're right. Thank you for your question. The decision to avoid APR and transanal endoscopic microsurgery was influenced by the goal of minimizing invasiveness. Considering the patient's comorbidities and the co-occurrence of esophageal squamous cell carcinoma and the rectal adenocarcinoma, which the squamous one is T3 and 1 and 0, and the rectal one is T2 and 0 and 0. A less invasive procedure like ESD was chosen to reduce the tumor burden while minimizing risk and recovery time. ESD was particularly suitable for patients' rectal lesion due to its size and location, offering an effective treatment with a low risk profile.
Great. So, but I actually have one concern. Is whether ESD, do you think that deep margin is sufficient, or whether we should go for a endoscopic full thickness resection to achieve a better deep margin? So what's your thought?
In this particular case, the tumor downstage to YT0, the pathology showed the deep margin from the tumor with 2 millimeters. No tumor budding. As confirmed by the histopathology, the tissue margins obtained through ESD, both horizontally and at the base, were clean. This implies a thorough removal of the lesion by ESD.
So do you believe that ESD can replace the surgical resection in patients that have been downstaged by this neoadjuvant therapy?
Well, thanks for the question. Currently, in patients with rectal cancer who achieve complete clinical response, CCR, after neoadjuvant therapy, the watch and wait strategy is often adopted. For those who do not attain CCR, but the tumor reduction into YT0, just like in this case, we can consider ESD. Considering the depth limitations, ESD may not suffice for pre-neoadjuvant therapy T2 to 3 rectal cancers as a curative modality. So in this situation, EFTR emerged as a potential alternative to surgical resection. But our goal is not to replace surgery, but to provide an option for a subgroup of patients.
Yes, I fully agree, especially for the high-risk patients. And you have demonstrated a very beautiful case of a ESD after downstagings, and you also mentioned that optimizing treatment strategy in your titles. So what do you think about the future trend in this particular field? Is there a role for endoscopy in these advanced cancers?
Actually, we are luckily in an era of precision medicine with immunotherapy for cancer. So we are lucky both for the patients and also for the doctors. I believe in the future, ESD and EFTR will have a role in the treatment diagram in the near future. We still need further studies to confirm who will benefit most from endoscopic treatment after downstaging of advanced cancer to achieve organ preservation, also with a long-term survival.
Yes, I fully agree with you, and I do look forward to the future result in this exciting field.
Thank you for joining me. Last but not least, I want to thank IGIE for the opportunity to publish the work, and thank you all the authors for the joint efforts. And thank Louis for joining me today. Thank you for the kind attention.